Ken Herrmann. I'm a nuclear medicine physician based in Essen, Germany. I would have loved to be in person in Vienna for Prosca, especially in the pre-Christmas Vienna, which is especially beautiful. However, due to some complexities of my wife's pregnancy, I had to stay at home. Nevertheless, I'm super excited to talk to you about regional lymph node staging by PSMA-PET. These are my conflicts of interest. None of them are really related to the content of my presentation. My talk is divided into 4 parts: a quick introduction on PSMA-PET imaging, especially because it's also today the first talk on imaging on the prostate cancer day. Then highlight with you the currently available data and how this actually reflected in the guidelines. And then last but not least, also discuss a little bit about nuts and bolts of how to report PSMA-PET, with special regard to lymph node staging. The whole diagnostic landscape has changed a lot compared to the pre-PSMA era. I want to get your attention, especially to the left part, because this is where we focus on diagnosis and staging. And you can see that initially, diagnosing testing comprised the PSA test. They're currently not so popular anymore: digital rectal exam, biopsy, and imaging-wise, MRI scan, complemented by eventually bone scan and/or CT scan. There are a number of different PSMA-PET tracers available, and you know quite a few of them. Many of them have seen the slide before. I still like the slide a lot because it shows you that a couple of differentiators are, for example, the U3 nuclide. On the left side, the 2 gallium compounds with a half-life of 68 minutes. On the right side, 4 fluorine compounds, half-life of 110 minutes. The second big differentiation is the way these tracers are predominantly excreted. So, for example, the ones on the left, the 4 on the left, they are predominantly excreted with the kidney. So we see a lot of physiological uptake also in the urinary bladder. In contrast, the 2 on the right, predominantly excreted via the GI tract, and therefore less uptake in the urinary bladder. Also important to mention, when you just look at the image, we see physiological uptake in certain organs, including the salivary glands, and overall you can see that the biodistribution of all these tracers is not significantly different, at least at the first glimpse. Now, this is an overview showing you the current landscape, which is currently, of course, evolving over time, but you can see that at least in Europe, we currently have 3 different PSMA tracers being approved. Gallium PSMA-11, different approvals, PYL, and as well as PSMA-1007. All 3 of them are available in Europe. In the US, also PSMA-11 and PYL are approved. And in contrast to Europe, here PSMA 7.3 is approved, whereas 1007 is not approved. And also important to highlight, there's another tracer coming, the Flu-18-CTT 1057. There, the phase 3 is completed, and the manuscripts are currently under review in a very important journal. So you see overall there are a number of different tracers available, so that this is now something which I think has significantly changed in the last years. Now shifting pretty quickly to the part of the currently available data, and very interestingly, the detection rate of lymph nodes in primary staging, where also the primary endpoints for getting these tracers approved. On the left side, gallium PSMA-11, the prospective phase 3 study. You can see here, primary endpoint was sensitivity and specificity for the detection of pelvic lymph nodes in patients undergoing primary staging with PSMA-PET prior to radical prostatectomy. And here, the results are pretty obvious: sensitivity 40%, specificity 95%. On the right side now, it's a phase 2/3 study. This time it's a Flu-18 labeled tracer, the PYL. Here, 250 patients with newly diagnosed high-risk prostate cancer were included. And even so, we talk about a different tracer, different centers. Still, very interestingly, the sensitivity was very similar, 40.3%. And again, also a very high specificity in this case, almost 98%. Now, complementing this data, which was performed both in the US, leading also to FDA approval, was obviously the very famous PRO-PSMA study with Michael Hoffman as the first author. Here you can see patients were prospectively randomized to either get conventional imaging consisting of CT and bone scan, or PSMA at first. And in case that there were no suspicious findings, patients were actually then crossed over to the respective other imaging modality. And when we look at this, we see very nicely here with the focus of the area under the curve that the red one, which is representing the PSMA-PET arm, is significantly more accurate, has a higher area under the curve compared to conventional imaging. And it becomes also very obvious that this is mainly driven with superiority here regarding the sensitivity. But also we see when we compare here for specificity that the values for red are higher than for blue. Now, remembering that the title of the talk is actually lymph node staging, we can look here very nicely that when we look at the primary analysis and we focus on the pelvic nodal disease, we can see indeed here significantly higher accuracy for PSMA-PET compared to conventional imaging, also a higher specificity. And this is the case also if you do a slightly different analysis. Again, you see the pattern matches higher sensitivity and higher specificity for a PSMA-PET compared to conventional imaging, which again, remember, comprises a CT and bone scan. And very recently, a new study, another PSMA tracer, I mentioned there's another tracer which is approved by FDA, the RH-PSMA 7.3, and here very interesting again, the co-primary endpoint actually was the sensitivity and specificity for detection of pelvic lymph node metastasis. And the results here, when you look at the majority treat, very much in line, high specificity, 96%, but the sensitivity again quite low here, even only 24%. So this is the data which is currently prospectively widely available. Now, how is PSMA-PET reflected in the guidelines? Very quickly, the EAU guidelines, I think this is very new, very current. So important to mention that here you can see patients with intermediate risk disease perform a prostate-specific antigen positron emission tomography if available to increase accuracy. The strength of the recommendation is weak. In contrast, in patients with high-risk localized disease or locally advanced disease, perform metastatic screening using PSMA-PET CT if available in at least cross-sectional abdominal pelvic imaging and a bone scan. So you see here, PSMA-PET is recommended, but it's more recommended actually to detect distant metastasis, not so much regarding local regional lymph node staging. Then this is German. I apologize for that, but this is taken from the German S3 guideline, initially implemented in 2021, where there's a clear statement that PSMA-PET CT can be performed in patients with high-risk prostate cancer, defined as a CT3, CT4, or PSA greater than 20, and this Gleason score between 8 and 10. Also important to mention, that's the reason I incorporated this, is that last week there was the update of the German S3 guideline, and I can tell you that this will in the future include a more strong recommendation. Actually, it should be performed PSMA-PET CT, and it will be also expanded from not only high-risk prostate cancer, but including now in the future also unfavorable intermediate risk prostate cancer. And also important here, the appropriate use criteria published under the lead of SNMI with a couple of other societies. And it's important to mention because the appropriate use criteria are the ones which are really reflecting what is going to reimburse or not. And when we focus again on localized disease, we can see here PSMA-PET is actually for primary staging recommended both in patients with high-risk prostate cancer, higher-risk prostate cancer, or in patients with high-risk prostate cancer who have M0 disease on conventional imaging. Now, moving over to the potential nuts and bolts, and I think it's very important to establish so-called standardized reporting. One of the most commonly available systems is the PROMIS V2. I quickly highlight this here. Of course, I have a certain vested interest in this because we started the PROMIS criteria initially in 2017 with Matthias Eiber as the first author. We have updated them last year in European Urology. And the main idea is really to establish, similar to the pathological TNM score, a so-called molecular imaging TNM score. And as we talked today about lymph node staging, very quickly here, the overview, how in the most updated version we recommend to describe involvement of lymph nodes. Here you can see if it's one lymph node involved, and it's MIN1, and we add by the two letters where the localization is, in case that there are at least two or more lymph node regions involved. we talk about MIN2, and again, add the information where the lymph nodes are involved. In case that we see extra pelvic lymph nodes, we talk about MIM1A, but again, please add the information in which part this was found. So in summary, I hope I've shown you that there are a number of PSMA tracers currently approved for primary staging. The guidelines clearly recommend the use of PSMA-PET for primary staging. Depending on the guideline, the degrees might differ. And again, for a large degree also, mainly to exclude or detect distant metastasis. Regarding the end staging, PSMA-PET clearly has a high specificity for all the investigated tracers, greater than 95%. The sensitivity is limited, ranged here for 40% for both PSMA-11 and PYL. In contrast, for ARCH-PSMA, it was only 24%. Even so, the numbers might be a little bit disappointing. We need to clearly state that PSMA outperforms conventional imaging for end staging by far. And something we need to know for the clinic, of course, is if there's no PSMA uptake in lymph nodes, it doesn't automatically mean there are no lymph node mets, because again, remember the sensitivity, especially if only small lesions in lymph nodes are represented, is limited. Imaging in prostate cancer is a very dynamic space. We all know very well how interesting and relevant APCC meetings are, which take place every 2 years. And to complement this a little bit more with special focus on diagnostics, which includes imaging, but not only imaging, we're going to have for the first time APCC diagnostics. And you see here 4 very important giants of nuclear medicine: Tom Hope, Lewis Emmett, Stefano Fanti, and Michael Hoffman. And all 4 of them also will be involved in APCC diagnostics. So I really encourage you to register. Thank you very much. And I really hope that next year I can be there in person again. Thank you.